afternoon, everyone. Our topic today will be about a very important subject in it's considered قريب منيح أقرب okay. Thermal management of a newborn infant is considered a cornerstone of neonatal care. Cold stress worldwide still a major problem and a major contributing factor in mortality and morbidity in this age group. That's why support and regulation of thermal management is of a critical care on those newborns. I'll start first of all with the definition of thermoregulation. So thermoregulation is the ability to balance heat loss and heat production in order to maintain body temperature in those babies in a certain normal range. As many pediatric associations, including the WHO and the American Academy of Pediatrics and ACOG, they define this normal temperature to be between 36.5 and 37.5 axillary temperature, meaning that there is no need for rectal temperature at all. This range of temperature will help the baby to stay in a neutral thermal environment. This neutral thermal environment is very important to maintain the baby in the least metabolic rate that is measured usually by oxygen consumption. Why we need this? Because minimal metabolic rate will influence the calorie intake of the baby, so he used the calorie to add weight instead of just warming up himself. As you can see from this illustration, within the neutral thermal zone, the baby will have the least oxygen consumption and metabolic rate, but going out this range with overheating or uncontrolled cooling, this will result initially in increase in the metabolic rate as a compensatory mechanism, but if we don't do the proper and timely management, the baby, eventually his metabolic resources will be consumed, and eventually major and serious consequences will happen, and that might lead to death. This is the primitive, and the first incubator was invented. It's actually invented by a French obstetrician who recognized the importance of hypothermia on mortality rate. And they found by implementing and using this wooden box with some source of hot water underneath, it helped to decrease the mortality rate on the low birth weight babies and sick babies tremendously. So afterward, more recent evidence showed that yes, decrease in admission temperature by 1 degree below 36 will affect mortality rate and will increase mortality rate usually by 28%. And from this, right now, admission temperature is considered an integral component of mortality scores in many NICUs. Hypothermia does not influence mortality rate, but it also has effect on short-term morbidities like RDS, pulmonary hemorrhages, sepsis, and hypoglycemia. So how the babies can keep themselves warm? We'll start with fetal life. So the fetus usually have high metabolic rate. His metabolic rate usually double the metabolic rate of an adult. That will keep the baby warm. It's almost like half degree above the maternal temperature. And the net flow of temperature is actually from the fetus to the mother, not the opposite. Taking the baby at birth from this warm and nice environment to our colder environment will have influence on babies. So how they will respond? So usually the baby have certain mechanisms to produce and conserve heat. Well, these mechanisms usually may be for a little bit effective in term babies, but if we have sick and low birth weight babies, these mechanisms doesn't help that much. Some of these mechanisms, we have the metabolic processes, which will involve the metabolism of fat, protein, and glucose in the major organs, liver, heart, and brain to produce heat. We have the voluntary muscle movements, and you can see the baby will start crying, he'll be restless, he'll be fighting, he'll assume the flexion posture to minimize heat loss and vasoconstriction. As we said, the ability to maintain temperature by these mechanisms depends on the health status of the baby and his gestational age. The main mechanism for those babies, in opposite to adults, are the non-shivering thermogenesis, which depend mainly on the metabolism of brown fat. Just to remind you with the brown fat, I did mistakes. We'll go back to the slides. Okay, so the brown fat. So the brown fat is distributed around the axilla, the interscapular region, the neck, and around the adrenal and the renal and the vascular areas. It represents about 4% of the total body weight in term infant. It starts appearing by age of 25 weeks of gestation and disappear between 6 months and 9 months of age, depending on the stress that the baby is exposed to. It's highly vascularized tissue, and just remember this mechanism working in a healthy baby, but if we have an extremely low birth weight baby or baby who are sick, those babies who are subjected to hypoxia, this mechanism won't work fully. So the brown fat metabolism will produce norepinephrine, there will be thyroid surge and thermogenin release. All will work into mitochondria for uncoupling phosphorylation to release heat and warm the baby for a little bit. The capability of baby to conserve and produce heat is limited. And we have many sources of heat loss that can influence the baby and affect him. So the heat loss mechanisms that I'm sure aware of are 4 mechanisms, major mechanisms. Just to review them very quickly, conduction is the direct contact between the baby and the colder surface, like a cold scale, for example, our cold hand or cold stethoscopes. The baby will lose heat to this colder surface. Radiation, which is a loss of heat to a source that's away from the baby. And usually this is the major source of heat loss in term babies. We have evaporation. This represents the major heat loss mechanism in preterm babies because the wet surface will evaporate and leaving the baby cold. And convection, which is the current of air. We have to, we know that there is consequences of hypothermia. There is a close association between temperature control and oxygen consumption and glucose metabolism. We know that when you're exposed to cold, the oxygen consumption will increase, leaving the baby suffering from metabolic acidosis and all its consequences on pulmonary vasoconstriction, decreased surfactant release, hypoglycemia, and etc. What we can see on babies, like signs on these babies, and I'm sure you've been called several times to look after a baby in the NICU or in the nursery who's suffering from shallow breathing or decreased activity or hypotonia, hypoglycemia or other problems, and most of the time it's not sepsis the main cause of these problems, but most of the time it's due to hypothermia. So how we can keep this balance between heat production and heat losses to maintain thermal neutrality? We have to implement strategies in NICUs and nurseries and delivery rooms to keep the baby warm. One of these strategies implemented by the WHO, the 10-step swarm chain, which is easy and simple and can be followed in most of the nurseries. It has 10 steps. The main 4 of them, I think, is to make sure that all the time, whenever the baby is there, whether in the delivery room, nursery, NICU, or at home, to have warm environment. The temperature over there should be between 23 and 25 degrees. So make sure when you attend a delivery and you're in the delivery room, the temperature to be under control. And make sure all the doors are closed, all windows are closed to prevent the convection heat loss and the air draft. Immediately after you receive the baby, you have to make sure to dry the baby with a pre-warm towels, and you have to change the towel repeatedly. Like you have to have, ahead of time, 3 or 4 towels that are pre-warmed and ready. Once you receive the baby, immediately change the wet towel and keep the baby warm most of the time. If the baby is stable enough, the best thing to do immediately after receiving the baby is to put the baby on the mother's chest or abdomen and continue the initial step of resuscitation on his mother's chest. This will prevent or minimize the conductive heat loss. Putting the baby on the warm mother chest will allow him to have more stable transitional course, will decrease the level of hypothermia, and this will increase the bonding between the mother and the baby. And the most important thing, this will give us the chance to initiate breastfeeding as soon as possible within the first hour, and its implementation, and that what will cause more success rate in breastfeeding. Of course, one of the important things that we're going to talk about, to postpone weighing and bathing of the baby. So we don't have to do bathing immediately. What we do usually, we take the baby from the mother's hands and rush him into the nursery, put him under the warmer, take his temperature. When the temperature is stable, we rush to give him his first bath. And this is wrong, actually, and might harm the baby. Even if the temperature is stable, that doesn't mean that the baby is really stable. Bathing the first bath should be postponed at least for more than 4 hours. The second day, you don't have to do it immediately. If for cultural reason or for family request, you can do it between 6 to 8 hours after the baby passed through the transitional period. This will allow, as we said, parents bonding. The parents can participate in bathing of the baby. This will make the baby transition smoothly. We won't have, I'm sure every one of you who's taking care of babies in the nurseries or NICU have been called for a baby who has poor feeding, or he has bloated or cyanosis or hypoglycemia immediately after bath. And you rush and do all the investigation to rule out sepsis, and we do sometimes admission to the NICUs and start antibiotic, and the whole problem is just hypothermia. So I think delay bathing is not well established on most of our nurseries, but it's worth trying by educating our staff, medical, and hospitals to delay bathing. When we do immediate bathing, if the mother has hepatitis B or HIV or C infection, then we have to bathe the baby immediately, and if there's MRSA or chorioamnitis. Of course, if we delay bathing, we have to use the universal precautions, wearing gloves, hand washing, and so on. For preterm infants, as we said, preterm infants is a different category because of they have more risk factors other than the term, and late preterm infants, they have less brown fat, they have less subcutaneous tissue, their skin is very soft and transmissible of all water, so they have special attention and special needs. For preterm babies, the most effective measures in the delivery room found to be increasing the temperature room to 26 instead of 23 to 25. That will improve the admission temperature and the temperature in the first few days by about 0.6 degree from the normal. This is especially for babies between 24 to 27 weeks of gestation. Adding to this, the use of a plastic wrap or bag immediately after the delivery. It doesn't need to be a sophisticated new wrap or something. You can use the kitchen bags that are usually used to preserve food. You just immediately after delivery slide the baby before drying into this bag, seal it from the neck, make sure to dry the head carefully, apply a hat, which preferably to be a wool hat over the head, and do all the procedures that you need to do. You can give surfactant, you can do lines, you can assess stability of the baby. Once he is stable enough, when you transfer him to the NICU, make sure that he is transferred in the plastic wrap. Weighing and all procedures should be done while he's still in the plastic wrap. Then, after you turn on the incubator, make sure the temperature is stable and turn on humidity. You put the baby inside. Once the temperature is stable, then it's the time to remove the plastic bag. We have different mechanisms to maintain thermal stability in NICU. The use of radiant warmer to minimize, as we said, the radiant heat loss, but it doesn't prevent evaporation or conduction heat loss unless we do the certain measures to prevent that. We have the incubators, and we have of course, the pre-warmed mattresses and the Kangaroo mother care. I'm going to spend a few minutes on the Kangaroo mother care because of its importance not only for term babies, but for also preterm babies. So it was introduced in the 1983 by Ray and Martinez in Colombia, and it aimed for the underdeveloped countries or countries who have limited resources and limited incubators to take care of the babies. So they used the mothers instead of incubators to take care of the babies for nursing and for taking care of these babies. Afterward, in the developed country, they start to implement this way for extremely low birth weight babies, and they found the kangaroo mother care will help to decrease the frequency of apnea, decrease hypothermia, risk of sepsis, improve the bonding between the mother and her baby, increase breast milk production, and success of feeding and early hospital discharge. Both parents can do the kangaroo care, the mother and the father, and you don't need extra staffing. It's just the regular NICU staff can do that if they receive the proper training. This is one of the NICUs and one of the our nurses. And the parents enjoying this moment. They feel that they are doing something for their baby and the baby seems comfortable. Having the baby on the ventilator or the CPAP or the Vabotherm or having lines is not a contraindication. It just needs more awareness of these and more precautions. There is specific intervention for at-risk infants. As we said, we have to have always pre-warmed incubators and warmers. Make sure after you've done all the procedures required on the warmer to transfer the baby to the pre-warmed incubator and turn the humidity on. Do not leave warmer bed open. You have always open transfer, whether from the delivery room or to the NICU or nursery or to the operating theater or to the radiology or anywhere to raise the rails up to prevent the convection heat loss. The servo mode should be not on the manual. Usually it has to be set on, and we're going to talk about the servo control in the subsequent slides. If you need to do a procedure, make sure that you have pre-warmed warmer, and if you need extra heat, you can use heat lamp or phototherapy. And you have to monitor temperature all the time to make sure that it's within the range that you want it to be. And if you want to use all fluids, liquids, it has to be pre-warmed. Cluster of care is very important. That means you don't have to open the incubators on and off frequently. You have to make sure that you have all equipment around, and if you need to do a procedure, you have to make sure that all procedures done in the certain and that single time. If you want to open the incubator, make sure to use the portholes, not the whole door, unless necessary. The skin servo control is better than air temperature control, and usually the servo control, the skin servo control should be well attached and make sure it's not dislodged, because this usually will cause the warming device to read the temperature wrongly, and it will alternate, so it will cause overheating or underheating. The cord, usually if you want to put the servo control, the probe should be not on the brown areas, as we said, the brown tissue areas, because then, especially the axilla, because then it will read the core temperature, not the actual skin temperature. And this will cause the warming device to cool the incubator down, and you'll then have the baby have to fight the cold temperature. He has to work hardly to warm up himself, and will end up with baby who is spending calories to warm up himself and not adding weight. And this is one of the causes when we have baby who's getting enough calories and not gaining enough weight. Role of humidity. Humidity can assist in thermal maintenance. It usually assists in fluid and electrolyte management, decrease insensible water loss, and maintain skin integrity. Usually we start humidity for extremely low birth weight babies or babies below 30 weeks of life, between 70 to 90. We start to taper temperature by around 1 week of age to around by 50%. We can see the humidity when the baby is 22 weeks or 32 weeks gestation, or if the humidity is at 40% and the temperature is stable. As we said, just to wrap it up, thermal management is very important and critical in a newborn, and it should be started immediately after birth. We have several mechanisms that can cause heat loss and heat production. Without our help and assistance of these newborns, they can lose temperature easily. Just remember 3 things. Delay bathing should be implemented right away in all nurseries, and this needs training and like cooperation from all staff, medical staff. Skin-to-skin contact is the same thing. Usually we rush the baby to the nursery. We don't give the mother and the baby the chance to stay together. And it's very successful in initiation and continuing breastfeeding. And finally, the use of plastic wrap and to cover the scales when you weigh the baby, and keep the wrap all through the procedures till the baby gets inside the incubator and with the humidity and the temperature is stable. Thank you.